has done his MD in palliative medicine from Tata Memorial Hospital, Mumbai, and now he is working as an assistant professor in Kasturba Medical College, Manipal. So he has been in palliative care for a few years. Um, and welcome, Pankaj, and it's over to you.
Yeah, thank you so much, sir. Thank you, sir, for giving me opportunity to present on this topic, a very important topic. Okay, so I will share my screen from here. Uh, yeah. So is it visible? Do I need to make a full screen, or you can see only the slides? No.
Sir, can you make it full screen? That would be better, sir.
Okay. Slideshow. Okay. Yeah, fine. So good afternoon, everyone. I am Dr. Pankaj, and we will talk here about the emergency in palliative care. Here, it's a very common topic that when you see a patients in palliative care, a lot of emergencies comes, and how we should manage, it's important. So in any case, if there are any doubts, clarification, or suggestions you have, you can put it in chat box, and at the end of the session I will try to take uh, uh, those clarifications. Okay. Or else, if possible, you can unmute yourself, and also you can tell. Okay, so because we don't have too many people, you can unmute also, and you can pitch in between. Okay, so emergencies, as Sunil sir told, like it's a very important to talk about the emergency and what all emergencies we have in palliative care, that we will talk. Before that, what is emergencies, in especially in palliative care? So emergencies are the conditions which can affect the patient's life or quality of life. Any of two, because in palliative care especially, we focus on quality of life, but also we do not want to shorten patient's life, and especially when it is correctable. And if we do not do those interventions, it can lead to patient's death, or can significantly worsen patient's quality of life. Raju Lakshmi, if at any point, if my voice is not clear, just let me know. Okay,
Sure,
because
sir.
I'm not using the microphone now. Okay, so when we are managing emergencies, a common principle that we should have in our mind, some questions that we should ask before managing the emergencies. So you before even a patient comes with emergencies, we have to identify the patients, or status um, um, identify those patients who are at the risk of emergencies. For example, a patients with head and neck cancers, or large wound, they can be at the risk of uh, 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 the torrential bleed, or carotid blowout. So, or those patients with a spinal metastasis may be at the risk of spinal cord compressions. So those patients we have to identify, and we have to tell them what to do when such emergency arises, or what we can do to prevent those emergencies, and that is very important. Then we have to identify what is the problem, what because of this emergency, what problem can occur. And we have to ask ourselves whether it can be reversed or not. So after reversing the condition, will he come back to his previous stage or not? What will be the effect of reversing that condition on the patient's condition? Will it cause any other significant morbidity to the patients or not? What is your medical judgment? And then patient's autonomy, what the patient and their caregiver want in such condition. And uh, uh, treating that condition, whether it can improve patient's quality of life or even sometimes it can worsen also. So that we will discuss in this. Okay, so what are the common emergencies? So we have classified according to the system. So in the neurological, if we see, it's very common, especially in the cancers, are malignant spinal cord compression, raised intracranial pressure, delirium, or status epilepticus. Metabolically, the common one are hypercalcemia, hyponatremia, or hypo or hyperkalemia. That's potassium. And then in GI, mainly malignant bowel obstruction, respiratory, the airway obstruction, or in vascular SVC obstruction. Sometimes patients may come with thrombosis also, or embolism. So that can be an emergency. And then hematological, hemorrhage or massive hemorrhage, especially in renal patients with obstructive uropathy or renal failure. uh, and then fractures, patients especially who are elderly or who are sick may have chances of pathological fractures. And then a very common emergency that we see is the pain crisis, or I think most common emergency is pain crisis. And sometimes opioid overdose if it is not been titrated accordingly, or patient have consumed too many doses of opioids. And commonly we come across the sepsis part also. So a few emergencies we will talk in detail about their identification and management. Okay, so first is spinal cord compression. So spinal cord compression we usually see in patients with CA breast, carcinoma lung, or carcinoma prostate. These are three most common cancer that goes to the bone and causes spinal cord compression. Most of the compression occurs either at the dorsal or a lumbar region. So that is dorsal lumbar, most commonly in the thoracic vertebrae, then lumbar, then cervical and sacral. So what are the common symptoms that occurs in spinal cord compressions? Most common symptom is a low back pain, and that is depending on the level of obstruction. It is usually progressive. It increases with the time. Uh, it can be severe, or it can increase while lying down, while coughing, with some activities if he's moving around. Uh, because on lying down it compresses on the vertebrae, it can increase the pain and can prevent the sleep. And usually it has a radicular pain, a neuropathic kind of pain. So patients may have some tingling, numbness, burning, shooting kind of pain in on the leg or upper limb, depending on the level, uh, or may be associated with weakness. Weakness in the sense a deficit. So it may be motor deficits or sensory deficit. Uh, uh, okay. Uh, then on the sign, so usually patients will have a tenderness in the at that level that you can elicit. Then if it is a UMN lesion, patients will have UMN features. So exaggerated reflexes will be there, extensor plantars will be there. Mostly it can be spastic or flaccid also. Sometimes it is quadriparetic, or mostly it is paraparetic. Okay, this means these features are also there when it is a traumatic spinal cord injury also. So when you see a patient falling down from a tree, and you commonly see in the these symptoms also. So if patient had any vertebral fracture, it can also present as a spinal cord compression. So need not to be a malignant spinal cord compression in that level. Now, in the sensory, you can, if it's you can see a dermatomical level, especially if it is a thoracic vertebral spinal cord compression. So you can make out what at what level there is sensory loss. Then you have to identify whether it's a bowel and bladder are involved. So usually they may have some constipation, or urinary retention. Sometimes also they may not, they will develop incontinence also. Usually they may have a postural hypotension also because of sympathetic involvement and blood pressure changes. So how will you identify these patients? So most common blood investigations that we ask is the X-ray of the spine. But the problem is it has very low sensitivity or false negative rate. You may not be able to identify the lesion if it is not a big lesion on a plain X-ray. So ideally we should do an MRI. MRI has a best sensitivity and specificity, and uh, we can treat accordingly depending on the level of compression. Okay, so the investigation of choice will be MRI, but sometimes we also can go by the X-ray or clinical finding also. So on the pathophysiology, so what happens when there is a compression by in the tumor? Usually it causes a stasis of on the blood, and that causes a release of interleukins and prostaglandins. And these, because of the stresses as well as with the prostaglandins, it causes a vasogenic edema, and that edema usually causes a compression on the nerves or spinal cord, and that leads to the deficits, and if it is a prolonged edema, it can lead to ischemia also, and that causes the damage, a permanent damage to the spinal cord. Okay, so here in this slide only, and they have given the possible treatment options. So if we see what are the common treatment that are available. Okay, yeah, so in this slides only. So in the yellow box you can see in the first treatment is steroid. So the treatment of choice in patients with spinal cord compression, first thing is to make the patient immobile. He should not walk, he should not move, and ensure that he is on the bed rest, even if it is not a complete spinal cord compression. And if he has vertebral metastasis, he should use the braces to prevent the compression to occur. Start high dose of steroids. So usually 16 mg IV stat is the recommended dose, and then up from 16 to 24 mg of dexamethasone is given. Along with that, you can give NSAIDs. NSAIDs, the effect is it will inhibit the prostaglandins, and also it will reduces the pain. Okay, the next thing is you have to give a consultation to a radiation oncologist, so that a radiotherapy can be given to that area. If it is a single site of compression and that can be corrected surgically, maybe orthopedician or surgery people can decompress that thing, or maybe neurosurgery they can decompress, or may be considered for vertebroplasty. And then because it will have also neuropathic pain, so we should use medications for neuropathic pain. So that for pain relief we should use opioids and non-opioids, and adjuvants are important. So usually we can use pregabalin, gabapentin, or amitriptyline for neuropathic pain relief. If a patient has constipation, that is because of autonomic dysfunction, or maybe inactivity or using opioids, so we should start them on a stool softener. A combination, mainly stool softener, stimulant, or osmotic laxatives can be used. In some patients with spinal cord compression who has developed paraparesis and all, maybe sometimes more manual evacuation may be taught. In the patients with urinary retentions, they may require a catheterization or intermittent catheterizations can be taught to them. So this we discussed that dexamethasone, usually it is the first grade recommendations to use. Okay, so usually we start with 8 mg TID and 16 mg stat dose of dexamethasone, and it should be continued till the patient is started on some definitive treatment like radiation or surgical decompression, and then once it is started, we should start tapering it out. Uh, okay, I will not go for the radiation part. Usually it can be either fractionated or unfractionated radiation can be given to the area. Okay, so surgery, when the surgery is recommended, usually if and the neurological deficits are progressive, that is increasing even with the bed rest with the dexamethasone and all. If it is it involves any fractures in there, or if it is unstable, that means the fracture a part of the vertebral body can cause further spinal cord compression. At that time, it's advisable to do the vertebroplasty, or when the radiation may not help in the patients who are radio resistant. So like the patients with osteosarcomas or renal cell carcinomas, which are usually radio resistant, may not help. In that condition, radiation may not help. Uh, uh, in very few conditions, we do not see these very commonly. Chemotherapy can also help, especially if it's lymphomas or neuroblastomas or germ cell tumors, where chemotherapy may be helpful in even treatment of spinal cord compression. Our main thing is we have to identify early and treat early, because if we start treatment within the 24-hour, the recovery is much better, and we can prevent the long-term complications in these patients. Yeah, so this is the time from the development of motor deficit to the radiotherapy is the most important predictor. Okay, and the delay in the dialysis can result in the loss of mobility, bladder dysfunction, and decreased survival. Uh, and also the survival and quality of life also depends whether the patient was ambulatory or he was bedbound already at that time. Okay, so that was about the malignant spinal cord compression. If anyone has any doubt or suggestions, can put it in a chat. Okay. Then next comes the raised intracranial pressure. So again, this is a very important and very common presentation. Usually patients presents with three common symptoms. One is headache, persistent vomiting that may be associated with nausea or may not be associated with nausea, and some altered sensorium or some motor deficit maybe there. Uh, so headache, vomiting, and altered sensorium are the common this thing. Other signs may be seizures, some neurological deficits can be there. Usually it is acute in onset and it fluctuates over the course. So usually most of the patients have morning time and the symptoms are more. Commonly in the commonly cause of raised ICP are either it's metastasis or maybe the primary of the brain, or sometimes the infections also can lead to raised intracranial pressure. Okay. So what's the treatment usually? So again, the steroids are the treatment of choice. Here the dose is around 16 to 25 of 4 mg. Again, it's a 16 mg stat and 8 mg TID. Usually steroids starts its action within a day. So if there are no response with steroids, you can stop it after 3 to 4 days. If we have given for more than 3 days, we have to taper it slowly. So usually we recommend 4 mg every 3 days we can reduce. Okay. Because there are some side effects of steroids. It can increase in the blood sugars, so we have to monitor blood sugar level every 8 to 12 hourly. And if a patient is on long-term steroids, some patients, when we stop the steroids, they will start developing the symptoms of raised ICP, and they may need steroid for very long time, especially the patients with the primary brain tumors. So they may develop osteoporosis or hypocalcemia thing, and they may need a calcium supplement, long-term calcium supplement. The next drug that is very important is mannitol. So mannitol usually is given 20% IV for 3 times a day for 3 days. And then after that, there are no proven benefit of continuing mannitol more than 3 days. So usually after 3 days of mannitol, we change to oral glycerol. That is also an osmotic diuretic. And that can be continued at the home or while the discharge. Okay. Usually drug of choice are for pain, we recommend paracetamol. If a paracetamol is not able to reduce the pain, then naproxen is the next drug of choice. Usually we avoid opioids, because opioids, there are two risks. One is it can increase the, further intracranial pressure, and second thing is the chances of opioid toxicities or the adverse effects are more if patients with brain injury or raised intracranial tension, if we are giving opioids, the chances of side effect are more. Then if there are seizures, then we should give a loading dose of phenytoin, and we should start on oral or IV phenytoin. If it is not controlled with that, then lever is the second line, not choice. The definitive treatment is usually a whole brain radiotherapy in most of the cases. It is usually not given if the before raised ICP, if the patient's performance status was poor and if he was not ambulatory. And then third emergency that we usually see in patients in neurological emergency is the status epilepticus. I will not go in very detail, but the common treatment that we should give in hospice or palliative care settings is uh, we have to protect the airway as far as possible. And so here, many patients may have decided not to go for intubation and all. So maybe a lateral position with the open mouth may be needed. And then start treatment of either IV midazolam, or if a patient is at home or in the hospice where IV is not available, subcutaneous buccal or nasal midazolam can be given. So we usually give patients who are at the risk of seizures, we give a spray of midazolam. Usually it comes with midasip, and we tell them to take a spray if a patient has seizures, and continue it till the seizures stops. Okay, but it is mainly for those patients who are for the home care. Okay. Then if a patient is in hospital, we should start a loading dose of phenytoin, that is 15 mg per kg. If it is not controlled with that, then the next option is to add a phenobarbital, and the next is to induce the palliative sedation. Okay. Then comes the metabolic this thing. I don't know whether you will have a separate lecture on electrolyte imbalance. I will quickly cover the hypercalcemia and hyponatremia. So hypercalcemia is again very common, and it causes very severe side effect, and many times it can be life threatening also, because it has effect on your cardiac functions also. So common presentation that we have usually is vomiting or dehydration are two most common. a presentation that we got to know. And it is easily missed because many a times we think of GI cause of dehydration or vomiting, and we miss the hypercalcemia. So the common clinical feature, it can be neurological, that is irritability or delirium, more sedation. GI, as I told, that it may cause vomiting or constipation. And the renal, it can present as a dehydration or renal failure. And sometimes it is diagnosed incidentally on ECG with a widening of T wave or prolonged PR. Okay, so the treatment, treatment is first the identification. So when we measure the calcium level, so the formula, we have to measure the corrected calcium, because some of calcium is in ionized and non-ionized form, and if we do not know the albumin level that is bound to the calcium, we may not be able to estimate the corrected calcium. So it's important to know the albumin also. So always whenever you are sending calcium, you should send for serum albumin level also. So treatment here, we divide it into whether it's a severe hypercalcemia or mild hypercalcemia. In mild hypercalcemia, only the hydration can work. So usually in 3 to 4 liter in 24 hours. Even you can give them oral hydration also. Ask them to take a good amount of water. If a patient has any signs of heart failure or fluid overload or crepitations on the chest, then you can start on diuretics also. Although theoretically, it's in the pharmacological books that furosemide causes calciuresis, but it has been found that furosemide as his own may not have any role in decreasing the calcium level. But definitely, because we are giving too much of the saline or water, we can give furosemide to prevent the fluid overload. Then if so usually mild cases settles with only hydration. If it is severe, that means corrected calcium is more than 12, and then we have to start on subcutaneous calcitonin, and the dose is 200 international unit thrice a day, and a bisphosphonate. So bisphosphonate usually takes 24 to 48 hours to start working, and it may continue to work for a week also. So calcitonin starts working if immediately. So it's important to start calcitonin bisphosphonate. Then the steroids. So steroids, the recent guidelines says that there are no evidence of steroids in solid tumors, but in lymphomas and all, there are evidence to use dexamethasone. In these patients, we have to monitor input-output chart because they may have dehydration or fluid overload, electrolytes also, and venous pressure to prevent the fluid overload. Usually in hospice setting, or where it's not in the palliative care unit is not attached to the hospital, we should check at least once daily the calcium level. Um, and then if it's in the hospital, then twice daily we should check for the calcium. And even after correcting the calcium, we should repeat it again if we have given bisphosphonate, because very commonly if we had given bisphosphonate, there are chances that patient may present with hypocalcemia also. So this was about the hypercalcemia. In those patients who have a diminished renal function, sometimes denosumab can be used, but usually in palliative care patients, we do not use that. Okay. Then comes the hyponatremia. So hyponatremia is reduced salt level in the blood. But if we see the pathophysiology of hyponatremia, we will find out that actually it's a disturbance of water in our body. So we divide it into three parts. One is hypervolumic. Hypervolumic means patient has excessive water. So that is usually in the condition where the albumin is low. So it can be in the congestive cardiac failure, cirrhosis, or hypoalbuminemia as such. And then the second classification is hypovolumic. So that is because of the loss of uh, fluid or water. Along with that, sodium might also be lost. So that is like in the severe vomiting, dehydration, or diarrhea, or inappropriate use of diuretics can cause to hypovolemic hyponatremia. Third thing that is very common in palliative care patients or in oncology setting is SIADH, that is euvolumic. That means you will have a normal water content, but the sodium level uh, is low. So in these patients, you will see that patient's hydration is adequate, Mm, but the sodium is low. Usually the symptoms that are there are the most common symptoms are they feel fatigue, and they may have some irritability or may present with a delirium. Sometimes those muscular cramps may be there. Very rarely, especially in the patients with severe hyponatremia, they may present with seizures or coma also. Any patients who is uh, presenting with sudden disorientation or delirium or seizures, we should send for sodium also. Also in those patients who had severe vomiting and dehydration. The treatment depends on first what kind of hyponatremia it is, and then depends on uh, what how severity of hyponatremia is there. So if we classify it as hyponatremia mild if it is 125 to 135, mild. Then moderate, it is usually 120 to 122. Severe if it is less than 120. Usually if a patient is symptomatic because of hyponatremia, or if it is severe, then it requires the admission of the patient and the correction. For correction, there are two things we have to remember. Means, there has been a recent change in the guidelines. In this, I have given a previous one that we used to calculate the rate of infusion that has to be given, and what duration of sodium bed that has to be given, the deficit and all. Now, in the recent guidelines, they say if it is, I am talking about SIADH. First is we have to restrict the water. So usually if it is not in very tropical situations or where the humidity is more, we can give up to 1 to 1.5 liter of water, with a salt restriction also. So salt usually we give up to 15 gram. Okay, so it's important. We have to restrict the salt, but also we have to uh, sorry, I'm sorry here. We have to give extra salt here. So usually we give 15 gram of salt every day, 5 gram every 3 times, or extra salt in diet. If patient has NGT, then extra salt we can add in their tube feeding. Correct the cause. So usually if patients may have some sepsis or infection, that may cause this thing. Fludrocortisone, especially in the patients who have long-term hyponatremia, or in those patients whom RAS is affected, fludrocortisone may help. Tolvaptans, again, it has been proven benefit of SIADH of idiopathic etiology, but it should not be used in patients who has liver dysfunctions. Okay, then important treatment, that is 3% NS. So we usually give 3% NS. So before giving NS, we have to diagnose. It should not be hypovolemic hyponatremia, and it should not be hypervolemic hyponatremia. In both the condition, 3% NS may not be useful. So in the cases where we have made a diagnosis of SIADH, there 3% NS is given. So new guidelines says we should not correct sodium more than 4 to 6 milliequivalent in 120 in 24 hour. Previously it was around 10 to 12, but the newer guidelines says 4 to 6 milliequivalent. And then they say to give NS more faster. So like 0.5 to 2 ml per kg per hour can be given. So if we take a patient with 50 kg, so we can start at 25 to 100 ml per hour, 3% NS. And then frequent sodium monitoring. So more frequently we should monitor the sodium. If a patient is in a hospital, maybe every 4 hourly you can monitor it. If a patient is in hospice or at home, you can monitor it at maybe 8 hourly and all. Okay, our target should be 4 milliequivalent. If the patient's sodium in the next report it increases by 4, and we see that patients has some improvement in his complaints, then that makes the diagnosis that this symptom was because of hyponatremia. This is important. If a patient's symptoms does not increase, does not improve with the increase of sodium level by 4, then we should see for some other causes. Mostly in that condition, the hyponatremia is not the cause of that condition, that symptom. Okay, I hope I was clear. Okay, so that was about the hyponatremia and hypercalcemia. The third is the vascular emergency, that is airway respiratory emergency, that is subacute airway obstruction. So it may be the intrinsic emergency or maybe extrinsic thing. Okay. So many a times we see patients, especially with lung cancers or mediastinal tumors, or the patients who have cervical lymph nodes. It causes the compression of the trachea, and the patient presents with stridor. Very common emergency, especially in head and neck cancers and thoracic cancers. Also in CA breast with mediastinal lymph nodes, and that causes stridor. So how we can identifying it in early, if we do a careful examination, chest examination by stethoscope. So usually these patients will have subclinical stridor. Stridor is identified usually by musical sound when it is in the inspiration, especially. So usually the ground rule is, if it is expiratory, it is more of a small airway, and that is wheezes. If it is inspiratory, it is more of larger airways, trachea or tracheals, and it is that is called as stridor. Okay, but it, in total obstruction or a severe obstruction, it may be inspiratory and expiratory also. So the treatment is, if a patient is hypoxemic, oxygen, start immediately on high dose of steroids. So again, 16 mg, 8 to 16 mg of dexamethasone is the drug of choice. Try to identify if what is the role of tracheostomy in those conditions. This is important because not all patients we should consider for tracheostomy. It is very important, and maybe when we discuss about the ethics, that may come out, especially in those patients who are toward the end of life. The tracheostomy can worsen their quality of life very significantly. Okay, but if a patient is has a good performance status, and you expect their lifespan that is good, then you should consider for tracheostomy. Okay, at that time, if a patient has respiratory distress, then using opioids or benzodiazepines can be used. Okay. I think I'm going a bit late and slow. I see. Okay. And then SVC obstruction. So SVC obstruction, it is the superior vena cava obstruction. Again with the thoracic malignancies or metastatics, it compresses the superior vena cava. And the symptoms depends on the level of obstruction. So if it is at the level of azygos, above the level of azygos or below the level of azygos. So what happens usually if it is a chronic SBC obstruction, there will be collaterals developing, and the patients may after some times may develop the collateral system, and the breathlessness may reduce after some time. But if it is acute, he will require the treatment. So usually the presentation here is the patient will complain of the dyspnea, the swelling in the upper extremities, facial region, and in the engorged neck veins. Okay. Uh, Other thing you can see in the earlier stage is there may be some tongue edema or congestion of the conjunctiva you can see. Okay. Then if it is chronic, you can see some collaterals also. Okay. So that is about the diagnosis of SVC. And the treatment again is steroids. So and I think most of the obstructions, wherever you see obstruction or compression, the steroids are the treatment of choice, because it reduces the edema around the obstruction, uh, uh, and that is the role of steroid, high dose steroids there. Okay. So 16 to 24 mg of dexamethasone, radiotherapy, or if it is a lymphoma or a very germ cell tumor that is chemosensitive, we can consider for chemotherapy also. Lasix or like diuretics, I don't know how much role they have. Usually does not help much, and in some cases the bronchodilators can be used. Okay. In the patients, if it is because of some thromboembolism or some thrombus inside, the low molecular weight heparins can be used. In the acute cases, you can also use the unfractionated heparins also. Okay. And if it is some tumor that is causing intrinsic blockage in the SVC, patient also can be considered for stenting. So here in all the emergencies, the thing that we discussed earlier is we have to see if the patients will benefit from this intervention, especially if we are doing some surgical interventions like stenting, putting tracheostomy, uh, like this. Then we have to identify how much the role is, what will be the end result, and how's the patient's condition before this complication. Okay. Then comes the hemorrhage. How many slides we left? Okay, yeah. So hemorrhage, this is again a very common complication that especially if they have a big wound, or the patients with hematological diseases. In those case, patients, a lot of patients comes with severe bleeding that is not able, that we are not able to control. So we have to identify whether we will be able to control the bleeding or not. Okay, if we will be able to control the bleeding, especially if it is a capillary ooze, then we can use the local hemostatic or pressure bandages. Uh, then or some coagulant drugs like ethamsulate or tranexamic acid. In patients with liver dysfunctions, if it is because of coagulopathy, vitamin K or FFP can be given, fresh frozen plasma. If it is because of low platelet counts, then RDP or STP can be used. In patients with GI bleed, especially if it is ulcer related bleed or post radiation, we can start infusion of pantoprazole or the oral sucralfate can be used. Sucralfate can also be used in those patients with um, post radiation infection in or inflammation in the um, rectum that causes bleeding. The sucralfate enema can be used. If it is a tumor bleed, we can use the hemostatic radiotherapy, and that is important. But important here is what to do when a patient comes with major bleed. Many a time, the family members, the patients, they get very anxious because of bleed, and that the memory of that bleeding can be forever. That can be catastrophic forever. And we have seen the patients with PTSD if they comes if a patient or someone had seen a major bleed. So it is important to identify those patients, and then giving them dark towels so that they will not have a sight of the bleed, using adequate sedation. So again, we give sometimes the patients some midazolam ampoules or a nasal spray of midazolam that they can use transnasally or buccally for sedation purpose. If a patient is in hospice or palliative care unit, we can start IV or subcutaneous infusion of midazolam. Okay. Uh, Here, one more thing very important is the presence. If they have someone from healthcare facility there, it gives a lot of assurance to the family and to the patient, and just being there also when because a lot of patients we have seen with the carotid blowout, especially with head and neck cancers, having a large lymph node or a wound that bursts out, and at that time the even surgeons cannot stop the bleeding. But being there, calming the patients, calming the family members may have good outcomes. So, then fractures. So I will not go into the detail, but in the patients who have extensive fractures, especially in the weight bearing bones, and those patients, whether it's a lytic fractures are there, in those patients are more prone for pathological fractures. Also, those elderly patients who are osteoporotic have the risk of pathological fractures also. So there is a Merrill scoring system which give us an idea of risk of pathological fracture and the treatment. We see the four factor, whether it's upper limb, lower limb, or peritrochanteric fracture. How's the severity of pain, the lesion, what kind of lesion it is, whether it's a blastic, mixed, or lytic, and the size of cortex that has been involved. And according to that, the treatment can be used. So whether we have to fix it surgically, or sometimes palliative radiotherapy can be used, and all the time we have to give good analgesics to prevent the bleeding. Then third, and I think the last is acute pain crisis. Okay. So pain crisis is the situation where the patient complains of severe uncontrolled continuous pain, and that causes both the patients and family members in the severe distress. So usually these patients will have a pain score of more than 7 out of 10, that is severe pain. So we should consider it also as a medical emergency, and I had said earlier that it is the most common emergency that we see. So the treatment is giving the adequate analgesia. Usually we should give it by the IV route. Um, so IV or subcutaneous route we should use. The drug of choice are usually the opioids, because according to WHO letter, if a severe pain, we should give opioids. So we prefer morphine, IV or subcutaneous, both can be used. So drug that the dose depends whether a patient is opioid naive or patient is taking or already opioid. So if a patient is opioid naive, we can give 1 mg to 2 mg IV stat, and can be repeated again after 10 to 15 minutes. If a patient is opioid is on opioids, so we calculate on the breakthrough dose, that is usually 1/6 of the um, per day doses, and that can be given through we have to change it into the IV, and then we have to give it. So consider if a patient has uh, is on 60 mg per day of morphine orally, and if he comes with pain crisis, the breakthrough dose uh, will be 10 mg orally, and if we want to give it IV, then the dose will be 1/3, that means 3 mg of IV morphine should be given, and it has to be repeated every 10 to 15 minutes. Okay. Then other drugs that can be used is the dexamethasone, that especially helps in relieving the neuropathic pain and bony pain. If these drugs, lidocaine and ketamine, are the drug of choice, if patients come with severe neuropathic pain, because we see the neuropathic pain is usually resistant to opioids, and it may not help in opioids may not help in neuropathic pain. At that time, either we can give lidocaine challenge or ketamine infusion. Even sometimes we use it sublingually also, and the sublingual ketamine is used. Okay. Okay, the last thing is opioid toxicity. So usually if we use opioids carefully and titrate it slowly and according to the principles, we do not see the patients with opioid toxicity. When do we see these patients? Are usually when we rapidly changes the dose, one thing. If we are using the IV route that time. Third thing is IV and fast, I'm telling. Okay. Third thing, if it has been taken inappropriately. So sometimes if the patient has taken the double doses, or three, four times the recommended doses. Okay, one more common cause of opioid toxicity that has been seen is not writing the order clearly. If the patient, if the nurses doesn't know how to what dose of opioid has to be given. So it has been seen that giving the doctor has wrote 1 ml of the diluted morphine, that is 1 ml is 1 mg, but the nurses had given 1 ml, that is 10 mg of morphine, and so that 10 times of the doses has been given. So we have to be very clear when we are writing opioids. It has to be very clear, and if there is any confusion, we should ask the clinicians. Okay, so what are the common signs of opioid toxicity? One is respiratory depression. So respiratory depression, that means if a patient's respiratory rate is less than 8 per minute, or saturation is less than 90, and patient is clinically cyanosed. Okay. Uh, uh, others Other signs are the sedation, more confusional state, delirium, hallucinations. Patients will have pinpoint pupil, some myoclonic jerks in the hand or legs may be there, slowing of cardiorespiratory system. Some patients may present with seizures also, or sudden cardiac arrest also. So the treatment is usually on good hydration for the patients, IV hydration. And if there is a chance, if there are signs of respiratory depression or cardiopulmonary compromise, then I'm sorry, then we have to give naloxone. So the dose is, we dilute 0.4 mg of naloxone, that is 1 ampoule, in 10 ml of saline. Then we administer 0.5 ml of naloxone every 2 minutes till the respiratory stress status is satisfactory. And the few things that we have to be mindful that sometimes with giving naloxone, patients may develop again again pain and pain crisis may be there. Okay, so it's important to write carefully and explain to the patient and the nurses carefully the doses of opioids. Okay. So that was about the common palliative care emergencies. I'm sure there are a lot many, but that we are not able to cover in 1 hour. Okay. Thank you so much.
Thank you, Pankaj. So we can take a few questions.
Yes, sir.
Anybody, if you have any questions, please ask, or you can give it in the chat box.
I'm sorry, my name is not written clearly. I am Pankaj, not Mayank. Yeah.
Anybody?
Okay, so I didn't see any questions here. How often do you see the palliative care emergencies or any of these emergencies in your practice? As any one of you had seen? Okay. There is one question: are cauteries helpful in massive bleed? Okay. So usually cauteries are used to stop the capillary bleeds. If I am not wrong, I am not a surgeon. Okay, but as far as from my internship knowledge, usually it is used for a capillary bleed and minimal bleed. I don't think as a OP basis we should use cautery to stop the bleeding. If there are any we take a surgeon's opinion if they are able to do some embolization or ligation of the artery, and then we ask for that the ligation or angioembolization of the arteries in case of bleeding, especially in the patients who have like there is capillary bleeds from the wound and that is from a single artery. Okay. Next question is injection dexamethasone dose recommendation is once a day or thrice daily better? Okay, so stat dose of dexamethasone in most of emergencies we give a stat dose that is 16 mg or high dose. Then we divide it into thrice daily. So thrice daily is important. That means we give it usually before evening. The last dose should be before 4 p.m. Many centers use it as like 210. So like if we want to give 24 mg, they will give 16 mg in the morning and 8 mg in the afternoon and not anything in the night. Some centers give it like 8 mg at 8 a.m., 12 a.m. and 12 p.m. and 4 p.m. So, but important is it should not be given in the night. Okay. Yeah, that's a problem that patients sleep is disturbed with the night dose. Yes.
Any more questions?
Good afternoon, sir.
Yes, madam.
So as you had mentioned that in cases of hypercalcemia, vomiting is a common symptom. But
Okay.
in palliative care setting and in many terminal patients, vomiting is, it can be caused because of a lot of other causes too.
Okay.
Wherein we generally say that a lot of investigations should not be done if the patient is already in the terminal phase.
Okay.
So how do we decide how to go about the diagnosis of hypercalcemia, or in that case, what will be the suitable treatment for vomiting in the terminal patient? like that.
Okay. Yeah. So I don't have any recommendations as such, but it's a very good question, and we usually have this doubt, like when should we do a calcium level investigation? Okay. So what we do, I will try to explain. Use first thing, identify the common cause. So if a patient is on opioid, if a patient has any constipation or any GI lesion that can cause vomiting, any cytotoxic drug the patient is on, a metagenic drug the patient is on, and that we should try to correct. If it is not helping, or the second when we think of hypercalcemia is if the vomiting is very severe, and many times it is not associated with nausea also. Okay, if the vomiting is very severe and dehydration is out of proportion of the vomiting. So because calcium itself can cause dehydration, it need not to be only because of vomiting. Okay, in that condition. Third thing is, usually hypercalcemia occur in which conditions, I will tell you. If a patient has lytic bone metastasis, uh, if a patient with head and neck cancers, especially in our population, although the literature is not much on that, head and neck cancers that is involving the mandible, or the mandible surgery has been done. So anywhere if the bone is involved, we had seen that hypercalcemia is there. Third thing is PTH related uh, PTH related peptides. So that is the cause of malignancy associated hypercalcemia. That is usually associated with CA lung. So CA lung and CA esophagus. So any patients with a lytic bone metastasis or fractures, mandibular involvement, CA lung or esophagus, the chances of hypercalcemia are more in such cases. So routinely we cannot use calcium in all the patients, but if it is severe and if we are suspecting the suspicion of hypercalcemia is more, we should see for that. Okay. uh, Sunil said, do you want to add something into that? Because I tried to read a lot about hypercalcemia, what are the recommendations when to see, but I could not
Yeah.
find out.
So I think hypercalcemia, if we suspect in the terminal stage, we are not going to treat. Isn't it, Pankaj? Pankaj,
Yes,
can
sir.
you hear me?
I couldn't hear you properly, sir. Yes, sir.
Yeah. I was asking whether are we going to treat hypercalcemia if the patient is in the terminal stage?
Mm, okay. Yeah. So if a patient is like we are identified the patient is in a terminal phase or actively dying stage. There are two things, like whether a patient has active symptoms, severe symptoms, and that is not corrected by using the antiemetics. At that time, I will go ahead for treating the hypercalcemia. I may not use the zolendronates and all, but for symptom control, I will try to correct it. If it is not controlled by other measures like using the antiemetics and all. Uh,
Yeah. So in the terminal stage, we are not going to treat hypercalcemia as such, but we will provide symptom relief for the patient. That's what we will do if the patient is terminal. That's what we usually do. So the question was regarding hypercalcemia in terminal stage. That's why I asked you that question.
okay, sir. Yes.
Okay. Yeah. So I think we will move on to the patient story. Uh, so this will be presented by Dr. Ramakrishnan from BSc Institute of Medical Science and Research Center, Coimbatore. Dr. Ramakrishnan, Pankaj, can you unshare your screen?
Yes. stop share. Okay. Yeah.
Evening all. I am Dr. Ramakrishnan from PSG Institute of Medical Sciences, Coimbatore. Hope I am audible.
Yes, sir, you are.
Yes, you are audible.
I am as a medical officer in one of the peripheral health centers. Recently, I have moved on to palliative care. I am in the department of oncology. So I am just sharing experience which we had recently. He's a 44-year-old gentleman who's a known case of non-small cell carcinoma lung and stage 4 disease with metastasis in liver and bone. Next slide. The patient, a known case of carcinoma lung, had presented at the emergency department with complaints of breathlessness since that morning. We also had pain over the left side of the chest wall, more on coughing and on inspiration. He also had both lower limb swelling for past 1 week, and he also had a superficial ulceration over sacral and buttocks region. He was not able to lie down. He's always sitting up. Only that position he was comfortable. So he had developed some bed sores also. The next slide, please. So the patient was apparently normal 6 months ago. He had cough and blood-stained sputum while spitting on a couple of occasions, and a breathlessness on exertion. He was evaluated initially at another hospital, and he had done a CT scan and other investigations and diagnosed to have CA lung with metastasis. There was a loculated fluid collection, and they attempted a pleural tapping, which failed. And they had also asked to take a biopsy, for which he was not willing for it. So he was treated symptomatically in that hospital and discharged against medical advice. He was at home taking out oral tablets for painkillers, and he was able to carry out the activities of daily living during that time. And slowly that breathlessness increased. So the day he presented, he was acute breathlessness was there, even at rest. He was very anxious. And there was a minimal cough with expectoration, and no any hemoptysis, no associated pain, which are significantly for the pain over the chest wall. So on examination, the patient was conscious, oriented, anxious, moderately built and nourished. Pallor was present. Significant bilateral lower limb swelling was there. He was in the sitting posture, unable to lie down. Respiratory rate was around 30 per minute. The pulse 106 per minute. Blood pressure was 100 per 70. Saturation without oxygen itself, it was at around 94 at room air. The heart sounds were heard. Uh, right side, the lungs air entry was good. On the left side, there was no air entry on the upper lobes. There was a few basal creps at the lower lobe. Abdomen, mild tenderness, the right hypochondria. The next, please. Investigations. The old scan showed the mass. It was inframammary and extending around 10 to 7 centimeters. The X-ray also didn't show any pleural effusion as such. What showed the diffuse mass. and the WBC count was around 15 with neutrophil predominance. Platelets were adequate. Hemoglobin was around 10.5. Blood sugar was marginally raised around 160. There were liver mets, and his alkaline phosphatase was around 444. Proteins total was 6.6, and serum albumin was low, 2.8. Urea creatinine in the normal range, and electrolytes, sodium was less, 115. Then later when we did the lung biopsy, they were very keen on, though he had come for, we had suggested palliation care, the patient and the attender, his wife, they were very keen that they should try this palliative chemotherapy and do whatever possible. Even at that stage, they were very keen on taking it forward. So the next day, we had done ultrasound lung biopsy, guided lung biopsy. The FNAC also showed non-small cell carcinoma. The prothrombin was around 15 seconds, and INR was 1.46. Next, please. Regarding his psychosocial history, he is a native of Madurai, come to Coimbatore for purpose of work. He was working as a mess supervisor in a local college at Coimbatore. He was only an earning member. Wife is a homemaker. They have a 13-year-old boy who had developmental delay and attending to regular school, and he needs personalized care. So that was the reason why the wife uh, did was not willing for further evaluation and treatment at the previous center. So after personal counseling, we had explained to them everything, and they were very keen on continuing and evaluating his status. Whatever best could be done medically, they wanted to try it out, even at that stage. And another sad thing was they had a baby born with meningocele in January. The child also died a month after, and he's not got any good relationship with other family members. As college manager, he had helped with him with some finances. So even psychosocially also they were very much disturbed, and we tried our best to sort them out and comfort them and console them. Next, please. So these are the main concerns: is breathlessness, the pain management, nursing care for the bed sore, the counseling to alleviate the fear of death and depression of the patient, the wife's dependence on him, being the sole earning member, and the son also, the future also, he needs special care. So all that was bothering them, the financial and psychological support. Next, please. So what best we could do at that moment, we just helped them out. I think that posture was helping them out a little. Like he was unable to lie down because of that mass and the compression effect. He was feeling a lot better sitting up and leaning forward. So, and we also reassured him that the oxygen levels are not that low and it's not as bad as he thinks. So just to be a little patient, and we'll do the best possible for him. And we had given injection dexamethasone 8 milligram over 30 minutes on day one. The next day onwards, we shifted over to methylprednisolone, 250 milligram, uh, 75 ml per hour. Then nebulization with Livolin, 6 thali, we started with that. Budicort also, and he was on morphine 5 milligram for thali. For the acute pain, he was given tramadol 100 milligrams IV. And for his limb swelling, the albumin was very less. So the next day we had given him albumin infusion, 20% at 15 ml per hour, 100 ml. As his sodium levels was low, Like we had given him sodium chloride 3% to correct hyponatremia. And other supportive measures were given bisacodile and nutritional supplements and antiemetics, and along with the antidepressants we had given. So this was the acute management is oxygen, the reassurance, the posture, dexamethasone injection and nebulization. And for the acute pain, he was given tramadol. Next day, we had given him albumin infusion, and that evening we had given him the sodium chloride 3% infusion. Next, please. So even I'm new to this field of palliative care, so I am as an observer getting used to this. I'd like to have your suggestions and inputs, please. Thank you for the opportunity.
Thank you, Dr. Ramakrishnan. So we have a 44-year-old man who has advanced carcinoma of the lung stage 4. So the questions are: how are you going to manage acute breathlessness, pain, and counseling of patient and attenders, nursing care of pets, or supportive care for the son with special needs and financial assistance. So I would like comments from participants about management of breathlessness and pain management in the station.
Can I answer?
Yes.
Hello.
Yes,
Doctor, the acute managed breathlessness is probably related to the CA lung. So acutely, it could either be a collapse, a consolidation, or a pleural effusion, which is causing an acute breathlessness. Collapse or consolidation, if there's an infection, that could be treated. If there's a collapse of the lung, you can do a bronchoscopy to see if there's anything that can be removed. Ultrasound, the pleural effusion, if I remember right, what was mentioned was they couldn't tap it earlier. But maybe it could be if it's something that is causing breathlessness now, it's probably a larger effusion. So ultrasound guided tapping would also help with the in the immediate thing. So these three things will help immediately with the breathlessness. Apart from that, pain relief, if it's pain, which is also there may be an element of pain also which can cause breathlessness, that could help. Oxygen will help. So that could be with the acute management breathlessness.
Thank
Thank
you.
you.
Pankaj?
I'm sorry, sir. Yeah. Sir, I couldn't hear the question. Can you please repeat, sir?
So, do you have any comments on the acute management of breathlessness and pain management? So,
Yeah.
I think Dr. Anupama was, I don't know whether it was Dr. Anupama. So,
Dr. Neelima.
Oh, sorry, Dr. Neelima. Dr. Neelima was telling that it may be the consultation or pleural effusion. So, she was talking about bronchoscopy and pleural fluid aspiration, infection, treatment of infection,
Yeah.
etc. So,
yeah.
do you have any comments?
Yes, sir. So as we went through the history, and I really wanted to congratulate Dr. Ramakrishnan, sir, that it was a very good history and a very complete history about the patient. So, and it's a very common presentation that we have, especially in patients with CA lung. Okay, and many times it's very difficult to manage breathlessness. So as I can see, like USG was showing that there is a mass, but it was not mentioned whether the pleural effusion was there or not. But initially there were 2 attempts of pleural tap was done, and that was failed. So yeah, definitely if there is evidence of moderate to severe pleural effusion, and if it can be tapped, then it can bring down the breathlessness. Okay. Other thing, if I assume that it is because of the tumor that is there. Okay. Anyone wants to add something?
The tumor size was
It was tumor only. Okay.
the tumor size was large, sir, and there was a very small pocket of loculated effusion.
Yeah.
Loculated.
So I believe that cannot be tapped, or even the how much result of tapping the pleural effusion will have. I'm not sure if it is because of the tumor. So then comes the two management usually what we do. One is definitely the palliative chemotherapy if it has role, because nowadays with um, and jeftinibs and all, there are good oral chemotherapy that patient can take and that can help in reducing the breathlessness. That can be an option, but as a palliative care practice, and usually the opioids are the drug of choice in that case. So opioids, I'm sure that by now we might have discussed our role of opioids in intractable dyspnea. So starting patients on morphine, oral morphine, would be recommended if a patient is having breathlessness, and or increasing the dose of morphine if the patient is already on morphine. And if a patient is not able to take orally, then IV or subcutaneous infusion of morphine can also be can also be an option. Definitely with other non-pharmacological measures that has to be used. So if someone wanted to discuss the non-pharmacological measures that can be used.
From this, as
Yes.
Dr. Amrushan says, there was a big in addition to opioids, what else would you recommend?
Okay, so an addition of opioids. Okay, I'm sorry if I have missed that thing. Okay, so two things in the pharmacological measures. The sometimes benzodiazepines can be used if it is associated with significant anxiety and that is not brought down by the opioids. The second thing is non-pharmacological. So have we discussed, sir, non-pharmacological management of dyspnea?
Yeah, it was discussed in the breathlessness.
Yeah. So can someone, some of the participant can tell me what all non-pharmacological measures would you like to add?
So, making the patient sit in a propped up position,
Yes.
firstly, placing the, if possible, placing the patient close to the window,
Yeah.
or directing a stream of air or a fan close to the face. Holding a wet towel on the face can help.
Yeah.
Pursed lip breathing can be encouraged.
Yes. Yeah, that's excellent, madam. Actually, and if we see as for a palliative care settings, and these measures helps a lot, especially if we shift the bed near a window and with a good circulation of air, or putting a fan, even a handheld fan, a blow of air. It helps a lot, and unfortunately, it is not in the practice a lot. Not many people recommend these things, but upper lip breathing, keeping a fan, uh, and also I wanted to add some relaxation exercises. Muscle relaxation or relaxation exercises, physiotherapies, if it can also be added. That can be one this thing. I will take dexamethasone only if it is if some of the tumor is compressing an airway, a single airway. Then maybe using steroids sometimes may help. That is usually if mass is compressing and that is causing cut off from rest of the lung area. Okay. Usually, that debulking is usually not possible, especially in metastatic disease. So sometimes, yeah, on bronchoscopy they do, and they try to open up the bronchioles, but in the palliative care settings, we don't know how much it will be useful. Okay. But yeah, opioid titration and benzodiazepines are the recommended treatment for refractory dyspnea.
So pain management, as you are titrating opioids, that will also help with pain management.
Yes, sir. So
So
I had some comments on the pain
yeah,
management, that
yeah,
the medications
yeah.
that was there. If someone want to discuss that thing, can anyone? Um,
Directly, can you take the previous slide of the medication? Yeah.
the
No,
treatment
no.
slide. Next.
Next one.
Yeah.
Yeah.
So can someone tell how would you like to add pain management?
Anybody has any comments on this increase the margin? Dr. Jyotika says increase margin.
Okay. This one.
Unless you can go on.
Yeah. So yeah, as someone has told, like we should increase the morphine, and yeah, Dr. Neelim, you said like we can add an adjuvants. Usually we call it adjuvants. So it can be paracetamol or NSAIDs. Usually the step 1 drug. Now I will not prefer adding step 2 drug with step 3, like tramadol and morphine. It is not a good combination. Okay, tramadol is a weak opioid, and morphine are strong opioid. So adding both drugs is usually not recommended. If a patient is not comfortable, is not managed on oral opioids, and if you want to give IP, you can give SOS IV also, or infusion of IV opioids. The recommended dose, because we have just started 5 mg, to increase the oral doses. So next will be 10 mg, then 20 mg, 30 mg, like that every fourth hourly. And definitely using some adjuvants according to the pain. If it's a nociceptive pain, paracetamol or NSAIDs, or if it is associated with some other neuropathic pain and all, those adjuvants can be added. Okay.
Okay. And so I think there are some questions from the psychosocial aspect, counseling of patients and attender, supporting the son with special needs and financial assistance for families. So what can be done for this to assist them in the psychosocial concern? Son should rather be sent to specialist who will help. Dr. Jyotika. Anybody else? Pankaj,
Yeah, I really wanted someone else to add on this. Yeah, when we talk about palliative care, and I saw in the earlier chats, like it's almost at the end of in the lecture series. Okay, so when we talk about palliative care, we talk about the holistic management of the patient, and it involves the financial and social well-being of the patient. Yeah. So there are two issues. Like one was the patient was the sole earner. So we have to have some training for the wife. We have to refer them to a social program, and where the wife can do something for their earning, and definitely referring the son for to continue his education. So yeah, a good social support for the family, that I would tell. Yeah. Yeah, so wife, if possible, can be vocationally training. So till the husband is fine, or even we don't know what life expectancy husband has. So even after the husband's death, the palliative care goes beyond the death of patient. So even then, wife should be with some support group system, and if we can provide some social support and all. Yeah.
Yeah, we can try to get the help of other NGOs, or if there is a volunteer group, involve them so that the psychosocial isolation would be less, and they will be able to help the family financially and psychologically and socially also. So I think if the patient is going to be in community, volunteers would be a better choice for supporting the family psychosocially. Nursing care of for bed sore. Can anybody comment on this? Nursing care of bed sore?
So frequent change of position and bed linen, avoiding creases in the linen which has been spread, and monitoring for early changes. I mean, if there are already bed sores, we have to take care that they should not increase in number or severity.
Yeah.
And proper cleaning is important. Moisturization is another thing which has to be taken care of.
Yeah.
And avoiding sweat and superimposed infection
Yeah.
should be encouraged.
Yeah. So, please, Dr. Nirima says, please wise have to care for pressure. So, yeah. Those are points which we have discussed during the wound care. And uh, Pankaj, do you want to add anything else?
Yeah, so I think we have added already. The only thing, in the patients who are breathless, the difficulty is we may not have the options of changing the positions and all. The patients will be comfortable in a particular posture. Usually they are in the sitting. So if we want to make them in the lateral position or changing the position, sometimes practically if we see it is a bit difficult, although it is recommended. Okay. The changing posture may not be feasible for them. Using a good moisturizing cream or oil that is to prevent the bed sore is important. Second thing is if there is any bed sore, the early identification and management. Having if a airbed or water bed can be arranged, that would be better. Plus, so that yeah, that should be for the nursing care of bed sore.
Yes, sir. As you told, sir, he was comfortable only in that sitting posture. Any slight movement also is not tolerating it. So we had
Yes,
tough time.
Yeah, so that's a problem with the posture sometimes we have, but so at that time our need to early identification of the bed sore and a good hygiene is important at that time. Then nursing care is important.
Thank you.
So this patient is stage 4 malignancy, and if he doesn't have proper symptom control, he will not be able to lie down. There may be multiple factors which causing breathlessness. So I think our primary aim should be to give comfort for this patient, and as we can also discuss with oncologist whether any therapy is going to help him. But our care should be focusing on how to reduce breathlessness. Even if he is in such severe breathlessness and if it is he is unable to lie down even for a minute, then I think we should also discuss with the patient what does he want uh, about whether he willing for chemotherapy or are we if he want symptom control, which is the most important thing for him. So discuss the goals of care with him. And if he want symptom control and if he says, no, I don't want to go for chemotherapy and I would like to have reduce my breathlessness at any cost. I want to lie down. I want to sleep. Then I think we should do all the possible to reduce breathlessness, including sometimes maybe sedating the patient to reduce the breathlessness if other conservative measures are available. So I think we can wind up the session. Time.
Thank you all.
Yeah. So thank you, Dr. Pankaj, for being our faculty and explaining in detail the palliative care emergencies which we have to face and how we can manage. Thank you, Dr. Ramakrishnan, for coming up with a good patient story, and thank you all for your active participation. So we will see you next Tuesday. Thank you. Rajlakshmi?
Yes, sir. Sir, I'm sharing the feedback link. I think
Yeah.
there is some internet issues here and I'm not able to go through my email. Yes.
Okay. You can share it in the group.
Sure, sir. I will do it. Yep, got it.